Okay, thank you very much. And indeed, I think this is a very interesting topic, and I'm happy we have a surgeon here as well. So I'm a respiratory physician. I will not discuss surgery topics here. I just think in a neoadjuvant setting, surgery is there. I work in Erasmus University Medical Center in Rotterdam, the Netherlands. So here are my disclosures. So at the beginning of my career, and that's already more than 15 years ago, we could discuss for years about the value of adjuvant chemotherapy. There was a lot of discussion whether it really would lead to improved overall survival. And then we had this very important meta-analysis by Pignon, the LACE collaborative group. It was about the use of cisplatin. And what you see here, that we had all studies which showed benefit in the same direction. So in all these studies, adjuvant chemotherapy showed benefit compared to observation, both for disease-free and overall survival. And what you see is that the yellow curves, so the chemo-T curves, are all above the blue lines, the observation line. And we know that adjuvant chemotherapy leads to an overall survival benefit of around 5% at 5 years. And at the same time, there were also preoperative chemotherapy studies ongoing, but they all stopped because of these positive results in the adjuvant setting. So here is also a meta-analysis. What you see is that it's all smaller studies, so the confidence intervals are more broad. There's somewhat more heterogeneity in there, but it's still all the studies show the same direction, and therefore the meta-analysis could be performed. And also here it has been shown that preoperative chemotherapy shows better outcome than no preoperative chemotherapy. And with this, we end with people who prefer preoperative chemotherapy and people who prefer adjuvant chemotherapy. And I think probably there is not a real, for overall survival, not a real difference, but the difference is in delaying surgery or not. So, and this is, I think, important to stress, because this is what we a bit have forgotten probably. In this meta-analysis, both of these meta-analyses, it has been shown that the benefit is driven or more clear for patients who are treated with cisplatin. And over the years in the stage 4 disease, we are more and more cisplatin replacing it by carboplatin. And here you see, so for both in the adjuvant and in the neoadjuvant setting, the advantage is driven, it seems at least, by cisplatin compared to carboplatin. And this is also shown here in the ESMO guideline. In the ESMO guideline, they say there's a high level of evidence, at least for stage 2B or larger, to give adjuvant chemotherapy. And this level of evidence is the highest for vinorelbine cisplatin. We all don't like vinorelbine because of the neuropathy, so we replaced it by pemetrexed without very good data. And in this guideline it is stated that only when cisplatin is not feasible, you can replace it by carboplatin. So take this in mind when we are discussing the new trials. So, and this is one thing why we need long-term follow-up. And we also need long-term follow-up for the adjuvant trials I'm going to discuss. Because with long-term follow-up, you have the idea that there is more non-cancer related death in the patients who are treated with adjuvant chemotherapy. So probably this has to do with late toxicity, cardiac toxicity. We do not really know this. So therefore, it's interesting to see, can we have chemo or platinum-free alternatives? Well, I think we were all looking forward to these results of the IMpower 010 study. So this was the first trial, and there are many trials ongoing, on adjuvant immunotherapy in patients with resected non-small cell lung cancer. And this study included patients with stage 1B, with tumors more than 4 centimeters, to still stage 3A non-small cell lung cancer. Stratification was based on the PD-L1 test, as was proposed by Roche in the beginning, but is not used. So, but it's important that stratification was about this test with SP142, which takes into account immune cells as well. Patients had to be treated with adjuvant chemotherapy. You see a lot of schemes, but cisplatin was mandatory, and at least one cycle has to be given. There was no crossover, so this means that at recurrent disease, these patients could not receive immunotherapy in the study, but they could receive for sure outside of the study. Primary endpoint was hierarchical tested, and I will show you later on. It was disease-free survival, first in all the patients with more than 1% PD-L1 expression. Now by the other assay, the SP263, this was changed after enrollment of all patients, but before the analysis, and this test is more frequently used. And then it was in the patient at high risk of recurrence, so the stage 2 to 3A. The next step was in all randomized stage 2 to 3A patients, and the last step was in the intention to treat population. And here you see the hierarchical testing displayed. So when disease-free survival was positive in the PD-L1 positive group in stage 2, 3A, then the next step was to test disease-free survival in all stage 2, 3A patients, and the next step was the intention to treat population, and then the overall survival could be tested formally, and this was a secondary endpoint. So something about the baseline characteristics. Around 50% of these patients had stage 3A disease, so really high risk of recurrence. An important part of these patients were never smokers, and 40% of these patients were not tested for EGFR and ALK. So there were no new safety details, as we know from immunotherapy in patients with metastatic non-small cell lung cancer. And what we see here, that the study is positive for its primary endpoint in PD-L1 positive patients with stage 2 to 3A disease with a hazard ratio of 0.66, and you see there's no crossing of the curves, and they split really very early on, so after 3 months of randomization. The study is also positive for all stage 2, 3A patients, so independent of PD-L1 expression, but you see that the magnitude of benefit is less. And then we have the intention to treat population. Here it's a bit difficult because the hazard ratio is 0.81 with a p-value of 0.04, and it is stated in the manuscript that it is not positive according to the pre-specified rules. But for me, it's very difficult to see what is the reason why it's not positive, because it's set here that it is tested two-sided, and the level was set on a p-value of 0.05, and this is 0.04. But probably someone here knows how to explain this. But that means when you state that the overall survival or the disease-free survival in the intention to treat population is not positive, that the overall survival will never be formally tested. But for sure we can look at the curves, and here you see the curves for the intention to treat population for all patients with stage 2 to 3A disease, and here for the patients with the stage 2, 3A disease in the PD-L1 positive group. Next to that, this will not be formally tested. It is also so that the data are very immature. So we can only see that in this group of stage 2 to 3A disease and PD-L1 positive, that we there see some split of the curves, but we need to have somewhat more follow-up. And then we have the EMA, and the EMA always takes other decisions. So the EMA has approved atezolizumab in the adjuvant setting for patients with a PD-L1 expression of more than 50%, at a high risk of recurrence, and that means stage 2 and 3A, who do not have an EGFR mutant or ALK positive non-small cell lung cancer. So let's see how the data look for this population, and this was presented at ELCC. So we see here that in the patients with PD-L1 of more than 50% in the stage 2 to 3A disease, that only a minority of these patients had an EGFR or an ALK. But very importantly is that 40 to 50% of these patients were not tested for EGFR and ALK. And here we see the data for this population, so where the compound is approved by EMA. Patients with a PD-L1 expression of more than 50%, stage 2 to 3A disease, On the left side, you see the patients including EGFR and ALK positive, and the right side without this patient, but it's only a minority of patients. We see that we have a hazard ratio of 0.43. It's more or less the same the data in the group with and without EGFR and ALK. And it's important to know that patients without testing are still in this group. And then EMA has always very interesting things in their EPAR, and this is this is the Dutch one. At least the text is Dutch. So they have some updated data, because here they have a hazard ratio of 0.49 instead of the 0.43 as presented at ELCC. And the median disease-free survival in the best supportive care group is longer than in the data presented at ELCC. And you see that when you compare the patients at risk, that at a time point of 21 months, that changes the number. So the EMA used updated data for this. With regard to overall survival, I think it's important to know how were these patients treated at relapse. So there was no crossover, but you can give atezolizumab or immunotherapy as standard of care when it's available in your country. So take in mind that these are patients with a high PD-L1 expression of more than 50%, and I think nearly all of us would say when these patients have recurrent disease, we will treat these patients with immunotherapy, but only 40% of the patients were treated with immunotherapy at recurrent disease. And then we had the next trial, the PERS trial, and this was presented at the ESMO virtual plenary. And actually I was watching this virtual plenary and I thought, well, this will be a positive trial. I only was interested in the magnitude of benefit. But the data are a bit confusing and surprising, for me at least. But we know statistics is chance. This for me, probably the difference is chance, but we will hear. So it's more or less the same population, or it is the same population. The stratification was also based on PD-L1 testing, but also on disease stage. The use of adjuvant chemotherapy, because it was not mandatory compared to the IMpower study, and of geographic region. The PD-L1 testing for randomization was by the 22C3 test. And although adjuvant chemotherapy was not mandatory, it was strongly recommended. The study has two primary endpoints, disease-free survival in the overall population and disease-free survival in the PD-L1 more than 50% population. And the randomization was pembrolizumab versus placebo, so not observation. And the disease-free survival for patients with more than 50% was an exploratory endpoint. So although the chemotherapy was not mandatory, the majority of patients received adjuvant chemotherapy, and only 40% of patients were not treated with adjuvant chemotherapy. Here you see the co-primary endpoints. So this was the endpoint disease-free survival in the overall population. You see that it is positive with a hazard ratio of 0.76 and highly significant. So these were all patients and not selected based on the PD-L1 expression. And then we have here the next co-primary endpoint, disease-free survival in the patients with a high PD-L1 expression. And what we see here is that the difference is not significant. The hazard ratio is in favor of the adjuvant pembrolizumab, but there is a crossing of the confidence interval. You see that at the time point of 18 months, there is a lot of censored patients yet, so for sure we need a longer follow-up. But I think all of us expected there that the magnitude of benefit would be higher in this selected population than in the overall population. But it was not the case. Here you see all disease-free survival and all key subgroups. And what is important also is that when you look at the stage, you see that there's no benefit, seems to be no benefit in the patient with stage 3A disease. Whereas in the IMpower study, there was a higher benefit in this group of patients. There's more benefit in the patient who received adjuvant chemotherapy. There seems to be somewhat more benefit in the patient with non-squamous histology. And you see that there is no difference between the subgroups with PD-L1 expression. There was an update of these subgroups, and there are two important things here to stress. One is that patients with N2 disease did not have benefit when treated with atezolizumab. And I show you this because of the neoadjuvant data I will present later on. And next to this, you see that the patients, there's no difference between carboplatin and cisplatin because both were allowed in this study. For the overall survival, these data are very immature. Well, there seems to be no difference at this time point, but you see that there are very, very many censored patients over here. So we have to await longer follow-up. So how do these two studies compare, and what are the differences? Because can we understand why in the Pearl study there is no benefit, or the benefit is not driven by PD-L1 expression or high states? Well, there is a difference in the immune checkpoint inhibitor used. So atezolizumab is a PD-L1 inhibitor, whereas pembrolizumab is a PD-1 inhibitor. In the IMpower study, the control group was best supportive care, so when you really believe atezolizumab, you can probably stop observation earlier or have a more careful follow-up of patient in the best supportive group, especially when they have N2 disease. In the Pearl study, the control was placebo, and I think for immunotherapy, well, when you have adverse events, you know they are on immunotherapy, but a subset of patients do not have adverse events, so you are more insecure in which arm they are. We see there's a major difference in patients with a high stage enrolled. So the IMpower study enrolled 41 patients with stage 3A disease, with 30% of patients with N2 disease. Well, at least in the Netherlands, most of these patients will receive concurrent chemoradiotherapy instead of resection. In the Pearl study, this was only 30% stage 3A disease and only 19% of patients with N2 disease. There was a difference in the patients who received adjuvant chemotherapy, but in the Pearl study it was also 86% who received adjuvant chemotherapy, and the primary endpoint differs as I show over here. And next to this, I think it's important to stress that the majority of patients in the Pearl study, the EGFR mutation was unknown. It was 40% in the IMpower and 60% in the Pearl study. And, well, because in the Asia there are more patients with EGFR mutations, you see that 24% of patients were enrolled in Asia in the IMpower study compared to 18% in the Pearl study. Well, happily, there are more studies coming, and I think some of them will read out very soon. I think the BR31 probably will read out at the end of the year. And it's also interesting to see that we have a study, the ANVIL study, which has as co-primary endpoint overall survival as well. Because at the end, I think we are all interested to learn whether there is an overall survival benefit at all. So next to this, and it is exactly the same setting as we had with adjuvant chemotherapy. At the time, there are also running studies with neoadjuvant immunotherapy. And in this time, we are happy that these studies have enrolled all their patients and will not be stopped because the advantage seen in the adjuvant setting. So for me, the Checkmate 816 study showed very impressive results. It's the first randomized reported phase 3 study. It has a primary endpoint, a pathological complete response and events-free survival. It randomized between chemo, nivo and chemo, or chemo alone for 3 cycles, and there was optional adjuvant chemotherapy was allowed. In neoadjuvant settings, we are always a bit worried about the quality of the surgery and surgical risk. What we see here is that an important part of these patients also had stage 3A disease. The time to surgeon was in both arms less than 6 weeks. There was a similar to higher cancellation rate as in the known phase 1 to 3 studies, but it was similar between the experimental and the control arm. Similar duration of hospital stay, and there seemed to be more minimal invasive and less conversions and more lobectomies and more R0s in the patients treated with the immunotherapy. For me, these results are very, very impressive. So you see that you have a pathology, complete response rate of 24% and a major pathology response of nearly 40%. And you see that the depth of the responses is amazing and it's completely independent of the radiology downstaging. Here you see that there are surgical related adverse events, but they are comparable between the two arms, so it's not increased. What we see is that the outcome is driven by PD-L1 expression, as expected. And it's always, you have always earlier a press release than the results seen. So these results on event-free survival were presented at ESCR, but beforehand we had this press release and the FDA approval where the package already showed the curves. And I think these curves are very, very important. You see here that there's an early split of neoadjuvant immunotherapy compared to chemotherapy alone, and that there is a hazard ratio of 0.63. You see that the advantage is there in the stage 3A disease, so the patients with bulky tumors, and also that there is high advantage for the patient with a high PD-L1 expression. The event-free survival is highly correlated with a complete pathological response. And in the patients without this complete response, the event-free survival was a bit higher, but it was not significant. And you see here in these data represented at ESCO that when you split these pathology responses, you see that on the right side the event-free survival curve splits enormously, and when there is no pathology response, these patients do not have benefit of this at all. Here you have the overall survival data. They are also a bit early still, but I think that we see here a very impressive split of the curves. It's a key secondary endpoint, so results will come. I see that I'm a little bit late, so probably I will skip this part. And this part is that the pathology response is very difficult to assess by pathologists and seems to be very predictive. And probably we will have make decisions on this for another adjuvant treatment, but it is possible to do this digitally, so it's machine learning and probably better to do than by your pathologist. The Nadim trial presented at ESCO was a trial where we have in patients with stage 3 disease also comparing neoadjuvant chemoimmunotherapy versus chemotherapy. It's a very small trial. It was stopped early. These were the data we had from the single-arm study, and it showed also impressive progression-free and overall survival data with a three-year overall survival of 82%, and I look forward to what Corinne thinks of this, because there was no radiotherapy involved over here. And here we also see that this pathology response predicts who are the patients who have benefit, but next to this, also ctDNA clearance predicts the patients who have benefit both for progression and overall survival. When going back to the randomized Nadir trial, we see that we have here a complete pathology response rate of 37% in stage 3 disease and a major pathology response in half of the patient. I think this is really, really very impressive. This part I will skip. So to conclude, where are we now with neoadjuvant and adjuvant treatment? I think the data show that adjuvant immunotherapy for atezolizumab and also pembrolizumab shows there's an advantage for disease-free survival, and I think we all want to see whether there's an advantage for overall survival as well. The next question is, do we need chemotherapy? And take in mind that we have more non-cancer related deaths in the patients treated with the adjuvant chemotherapy. The data seems to be driven by stage and PD-L1 expression, but not in the PEARLS trial. Well, this can just be by chance, but I think we have to await the next trials. I think for now we have to exclude this patient with EGFR and ALK, but probably, in my opinion at least, also RET, ROS, RET, HER2, all these subgroups where we know that immune checkpoint inhibitors do not have benefit. In a neoadjuvant setting, this seems feasible, so that seems to be not more surgical complications, and probably the surgery is more easy as well, but there might be a selection of patients with high volume tumors where people were already a bit in doubt about resectability on forehand. Very impressive complete pathology response rate, leading to prolonged regression, disease-free survival, and we will see overall survival data. I look forward to the discussion of Corinne. How does this compare to chemoradiotherapy? And what will we do when these patients do not have a major pathology response and do not have ctDNA clearance? Do these patients need additional treatment? And is the adjuvant chemotherapy really required? So what is the future? The future is that we really have personalized treatment of early stage non-small cell lung cancer. We need to have an MDT where all specialists are in. So it cannot be a play between the respiratory physician and the surgeon. The medical oncologist has to be in there as well as the radiation oncologist, as the pathologist. We need to have molecular testing in all these patients on forehand before making a treatment decision. Probably the tumor volume and primary resectability leads the decision for neoadjuvant or adjuvant treatment, what to do with on forehand known N2 disease. And well, I discussed that we need different treatment for patients with driver mutations, and we need therefore tissue before resection and not only cytology. And next, the last point is that we have to deal with unplanned subgroup analysis by EMA, making us all worrying about how to value the EMA decisions. And with this, I'd like to thank you for your attention.
Thank you very much. So it's a pleasure to be here in Milan, and thank you again to Filippo for inviting me. And I couldn't agree more with Anne-Marie's conclusion about the fact that we need personalized treatment and very much a multidisciplinary team making decisions. So I've been asked to talk about local regional treatment. So these are my disclosures. So I had to choose what to talk about, so I can't cover everything because there's so much to say. So I'm going to start with a little bit on early stage non-small cell lung cancer and then move on to the most important part, which is the locally advanced non-small cell lung cancer with the role of immunotherapy, of course, and some new data on post-operative radiotherapy. So I am going to present, hopefully, some recent data from this year. A lot of it is still a bit controversial and talk about future directions, particularly with regards to the topic of where does chemoradiotherapy fit in. Now we have all this data on adjuvant, neoadjuvant immunotherapy and chemoimmunotherapy. I'm only going to focus on non-small cell lung cancer because I don't have time. There would be a lot to say in the small cell setting, but I do not have the time to do that. So let me just start with early stage non-small cell lung cancer. So we have about 20% of patients who present with stage 1 disease, and that is likely to increase dramatically in all of our countries. I mean, certainly in the UK, we're now implementing screening, so I think that group of patients is going to increase rapidly in the next few years, and hopefully we'll see less patients with stage 4 disease. It is clear that the standard of care, if a patient is operable, is surgery, but at least 1 in 3 patients are not suitable for surgery, either because they're medically inoperable, and that is the majority of the patients, certainly I see in my clinic, but some patients are operable but will refuse surgery, for example, if they're elderly. So stereotactic ablative body radiotherapy is an alternative to surgery. We can achieve excellent local control rates, and the toxicity is very, very minor in the majority of patients. However, what is important is that despite the fact that these patients have very early stage disease, the risk of distant metastasis is between 10 and 20%. And that is something that we've not been able to deal with. We know that the majority of patients having SABR are elderly, they're frail, they would not tolerate adjuvant chemotherapy, which is not considered in this group of patients, and we do not have any evidence. So with regards to SABR, so for those of you, I'm sure most of you in the audience will be medical oncologists, so SABR is the delivery of high precision radiation, very conformal plan with a very steep dose fall-off, so very little dose delivered beyond the target, very high dose per treatment and delivered in a small number of fractions. So nowadays, for example, in a tumor that is within the lung tissue away from central structures, away from the chest wall. We can even give one fraction of radiotherapy, which is extremely convenient, as you can imagine, particularly for very old and frail patients with low levels of toxicity. Up to 2019, actually, we did not have evidence of the efficacy and impact on survival and freedom from local failure of SABR versus conventional radiotherapy. But we now have that evidence from the study published in the Lancet Oncology by David Bull et al., comparing SABR, you can see there were different dose fractionations that were permitted, versus more conventional radiotherapy, either delivered with 2 grams per fraction or more hypofractionated radiotherapy. And you can see this big difference with a reduction in the risk of death of 47% with SABR compared to standard radiotherapy. Now, a big question that still remains is very much the question of, is SABR safe in tumors that are central or ultracentral? And you can see that there are 2 definitions of central. The first one on the left-hand side, which is the RTOG definition, so tumors within that no-fly zone, which is within 2 centimeters of the central airways. And then a new definition that was published in 2015 from the ISLC, which defines central tumors as tumors within 2 centimeters of any sort of mediastinal structure, which I think makes a lot more sense. So we have a study from the RTOG that has defined a dose fractionation of 60 grain 5 fractions, and then in Europe we tend to use more 8 fractions regimens. But what is important is that in the ultracentral tumors, so the tumors that are located really close to the main bronchi or the lower part of the trachea, there have been reports of very severe toxicities, as you can see from the paper in the New England Journal of Medicine, some necrosis of the airways, and then in a paper from the Netherlands, in ultracentral tumors, 15% of fatal pulmonary hemorrhage. So we're still very cautious in this specific group of patients with regards to the use of SABR. And then what is important is that, as mentioned before, there's a high risk of metastatic disease in this group who have early stage disease, and there's a very nice abstract that was presented, but I have not actually seen the full publication, showing that, of course, as the tumor size increases, there's an increase in the risk of local failure and distant failure. The majority of failures are within the first 2 years after SABR, and the majority are actually distant as opposed to local regional. As mentioned previously, chemotherapy would be considered to be too toxic in this population, and we know that IO alone has a tolerable toxicity profile, including in elderly patients, so there's certainly a rationale for adjuvant immunotherapy in this group of patients. And as you can see from this table, there are quite a number of ongoing trials. Majority are phase 2 studies, some are single institution. There is one randomized phase 3 trial, the Pacific 4 study, that is adding durvalumab after SABR. Some of the other studies either add the immunotherapy agent to SABR and also during the consolidation treatment. So that is very much awaited. I'm now going to move on to the locally advanced non-small cell lung cancer setting. And in this setting, really, what we want to achieve, let me just clarify that I'm talking about unresectable stage 3 non-small cell lung cancer. So with the chemoradiotherapy combination, we're aiming to achieve this balance between optimal local control, but at the same time, we want to minimize side effects as much as possible. We know that local relapse it remains a big problem despite advances in our chemoradiotherapy treatment, but most importantly, again, similarly to the early stage setting, metastatic relapse is a big problem, with approximately 50% of patients having metastatic relapse at 2 years. And with a drug radiotherapy combination, what we want to do is to modify that therapeutic window in order to improve both local control and survival. So there's therefore a very strong rationale to combine and optimize drug radiotherapy combination, including, of course, immunotherapy. So this slide summarizes the standard of care in inoperable stage 3 non-small cell lung cancer pre-immunotherapy era. So the standard of care was concurrent chemoradiotherapy, and we learned from the seminal RTOG0617 study that there is no role for dose escalation using conventional fractionation, and this study has defined what we consider to be the international standard of care of 60 grain 30 fractions combined with chemotherapy. Another really important message, which I will come back to from RTOG0617, is the importance of a radiation dose to the heart. And it was defined for the first time that actually above a certain threshold, the more patients are dying, and are dying actually quite early, probably of cardiac complications. In terms of the chemotherapy treatment, so we give cisplatin-based chemotherapy, either carboplatin or cisplatin-based. We've learned over the years from many randomized trials that there's no role for either induction or consolidation chemotherapy. And to this date, there is still no defined role for targeted agents, including in patients who have driver mutations. So we've been going round in circles for many years in terms of defining optimal radiotherapy treatments and defining optimal chemotherapy to combine with radiotherapy until the Pacific study, which was defined as a tsunami in the field of thoracic oncology and became a standard of care. So there is a strong rationale again for combining immunotherapy and radiotherapy from preclinical data. So we know that radiotherapy potentiates the anti-tumor immune response through a number of mechanisms that are summarized on this slide. But what we know is that the microenvironment is also very immunosuppressive and will dampen down the immune response, for example, through the interaction between the PD-1 and the PD-L1 receptors. So hence this investigation of immunotherapy in addition to radiotherapy. So just a reminder, many of you will be obviously very familiar with the Pacific study, which included unresectable stage 3 non-small cell lung cancer without progression after definitive platinum-based chemoradiotherapy, at least 2 cycles. The patients also had to have recovered from the side effects of chemoradiotherapy. It's important that to say that it's an all-comers population, so the pre-chemoradiotherapy tumor tissue was not mandatory to be provided in this study. And patients within 1 to 42 days after chemoradiotherapy were randomized 2-to-1 between durvalumab every 2 weeks for up to 12 months versus placebo. You can see the stratification factors, and there were 2 co-primary endpoints, progression-free survival and overall survival. So what is important is that we now have quite long-term data on both PFS and OS. So the 4-year survival data, so reduction in the risk of death of 29% and reduction in the risk of death or progression of 45% with the addition of durvalumab after chemoradiotherapy. And then these figures were updated again at 5 years and published recently in JCO. So you can see this very prolonged benefit in terms of addition of durvalumab and a difference at 5 years. So 42% 5-year survival with durvalumab versus 33% with placebo. Another aspect that is extremely important is that we were all very concerned about the risk of pneumonitis after chemoradiotherapy when adding immunotherapy. That was not the case. The rate of grade 3/4 pneumonitis was less than 4%, which was very reassuring. Now, in terms of subgroup analysis, most subgroup benefited at the exception of 2 subgroups, so patients with EGFR mutations, and I'll come back to that in a minute, and also patients with a PD-L1 of less than 1%. So as mentioned by Anne-Marie, the EMA does request unplanned analysis, and this was the case. The pre-specified analysis was with cutoff of 25%. This was unplanned, but as you can see from the bottom here, no benefit in the less than PD-L1. So that led to actually a differential approval in different settings. So for example, in the US, the FDA approved durvalumab for all comers. In Europe, that wasn't the case, and certainly not in the UK. The approval is in PD-L1 of more than 1%. Also important to note that EMA and FDA approved durvalumab in patients who had received chemoradiotherapy. It wasn't actually specified it had to be concurrent chemoradiotherapy, but for example, in the UK, NICE has only approved the drug in patients who receive concurrent treatment, so we cannot prescribe it, for example, in patients receiving sequential chemoradiotherapy. Now, this is the post-hoc analysis presented at ASCO this year by Dr. Naidu in the patients with EGFR mutation. So as you can see from the PFS and overall survival curves, the outcome with durvalumab was similar to placebo, but with very wide confidence interval. Importantly, to consider that the safety data for durvalumab in this EGFR mutated subgroup were consistent with the overall population, so no difference there. But we have to be very cautious, of course. We're talking about a very small population, 35 patients out of 713 patients, imbalances in baseline characteristics between the treatment groups, and clearly this trial was not designed to evaluate clinical outcome according to EGFR mutated biomarker status. Now, the ESMO published this expert consensus statement on the management of EGFR mutant non-small cell lung cancer, which I had the privilege to be involved with. And there were two important questions that were asked in this group of patients. So in patients with EGFR mutation, inoperable stage 3 non-small cell lung cancer undergoing curative intent chemoradiotherapy, what is the role of consolidation immune checkpoint inhibitor therapy? And this is what the group concluded. In this group, the use of consolidation ICI therapy after curative intent chemoradiotherapy is not recommended. The second question is in patients with inoperable stage 3 non-small cell lung cancer with an EGFR mutation, what is the role of TKI pre, post, or during radiotherapy? And again, no role in this setting, which we discussed a little bit yesterday afternoon. Now, new data that was presented by Marina at ELCC this year, and the paper has been submitted, is on the Pacific 6, so in patients who have sequential chemoradiotherapy. And I understand that in Italy, similarly to the UK, you prescribe quite a lot of sequential chemoradiotherapy still in patients with unresectable non-small cell lung cancer, as you have many patients who are elderly and frail. This study is not randomized, so it's a single-arm, multi-center study where patients who had sequential chemoradiotherapy went on to having durvalumab for up to 24 cycles. There were two cohorts of patients, one with good performance status 0-1 and another one with PS2. And it was foreseen to include up to 30 patients in that PS2 cohort. So as you can see, and not surprisingly, the majority of patients were above the age of 65. Very few patients actually were enrolled in the PS2 cohort, only 2.6% of all of the patients. The majority of patients had stage 3B disease. Majority had adenocarcinoma, and important to say that the PD-L1 expression level was not available in 40% of the patients. 117 patients were enrolled, and the number of prior cycles of chemotherapy was 4. Most patients had 60 gray, and the time from radiotherapy to durvalumab start was a median of 26 days. If we look at a median total treatment duration, it was 32 weeks, and as you can see at the time of the presentation, some patients, so almost 40%, were still ongoing treatment. The main reason for discontinuation of durvalumab was progressive disease and adverse events in 21% of patients. The primary endpoint of the study was the incidence of AEs that were possibly related to the treatment. And as you can see, there were 5 patients who developed grade 3 3 to 4 possibly related adverse events to treatment within the 6 months of starting durvalumab. So the incidence is 4.3%, which is very reassuring in this group of patients, and you can see what these events are. One patient died as a result of treatment, and 16% had adverse events leading to treatment discontinuation. In terms of efficacy, the PFS and OS, you can see at the top, compare favorably to historical cohorts treated with sequential chemoradiotherapy, in which most patients progress within a year. So if we take that together with the fact that durvalumab has a similar safety profile to that observed with durvalumab after concurrent chemoradiotherapy in the PACIFIC study, I think this is quite encouraging data. And we have a PACIFIC-5 study that is going to report soon, hopefully, that has been assessing the efficacy and safety of consolidation durvalumab in either concurrent or sequential chemoradiotherapy setting. So this slide summarizes progress made in 4 decades, all the way from radiotherapy alone in the 1980s, and then with better integration of chemotherapy and radiotherapy, particularly with the concurrent integration, also some improvement in radiotherapy techniques such as IMRT, and then finally to the addition of durvalumab, we've gone from 10% 2-year survival all the way to 66% 2-year survival, which I'm sure you will agree is major progress. We have many trials ongoing. I've not had time to show you this with other immune checkpoint inhibitors. Obviously, durvalumab is the drug that is approved, but many others are ongoing and will have results soon. And there are also a lot of unanswered questions around the duration of consolidation immunotherapy, the timing of chemoradiotherapy and consolidation immunotherapy, and many more. So I'm looking forward to hearing more on that. Now, I'll quickly tell you about the Long-Out study, which is data that's been published by Cécile Lepechou this year in Lancet Oncology. So in this study, patients with completely resected stage 3 disease were randomized 1-to-1 between control and post-operative radiotherapy. Primary endpoint was disease-free survival. And you can see that there was a non-statistically significant 15% increase in DFS, but the p-value was 0.16. Now, the 3-year disease-free survival was higher than expected in both arms, and I think that reflects on the quality of the surgery and the radiotherapy in this study. Now, what is also very important is that the mediastinal relapse rate was reduced very significantly with PORT, so it's important to acknowledge that. Almost 50% of patients had mediastinal relapse in the control group versus 25% in the PORT group, and you can see the overall survival, no difference at the bottom, but also, again, very, very good overall survival at 3 years, which is important to keep in mind. What Long-Out has also highlighted, and I'll come back to what I said about RTH0617, is the importance of the radiation dose to the heart. There were more cardiopulmonary deaths in the radiotherapy arm, 16% versus 2% in the control arm, and more toxicity, of course, overall. So the conclusion is that conformal PORT cannot be recommended as a standard of care in all completely resected patients. But bearing in mind this very high relapse rate in patients who do not receive PORT, so there's probably a need for postoperative surveillance. There are still some questions, for example, in patients with extracapsular extension. And we have, as I said, excellent survival in the control arm, and really we have this debate that remains between a surgical versus a non-surgical treatment, particularly in the IO era, and the importance of limiting radiation to the dose of the heart. So there's a lot of research ongoing, including in my institution, where we're now implementing dose limit to the base of the heart, and we're doing that in a very systematic way in the setting of the national program grant. Now, Anne-Marie asked the question earlier, so what is the view of a radiation oncologist? And I think we have to now bear in mind that we're are in an evolving era of adjuvant and neoadjuvant chemo IO with examples that were given by Anne-Marie. And I think really now the time is ripe to think about studies comparing a surgical to a non-surgical approach in the immunotherapy era with primary endpoints of PFS, OS, but also very importantly, I think quality of life needs to be considered, and patients' preference also needs to be taken into account when thinking about various strategies. In the UK, we have a feasibility study that is recruiting, that is comparing a surgical to a non-surgical approach, but that is only a feasibility study. We're hoping that this would lead to a larger phase 3 study. And these are my conclusions. So for the early stage setting, in terms of systemic treatment, there is no role yet for immunotherapy in this setting. Clearly, it is the case in the non-small cell unresectable setting. Metastatic and local control remain a challenge. We clearly have a complete landscape that is changing all the time. Consolidation IO is the standard of care. There is no role for PORT after complete resection in the routine setting, and there's a real unmet need to compare a surgical to a non-surgical approach in the IO era. And the key message, as always, is please enroll patients in clinical trials so we can have the evidence to treat our patients in the optimal way. Thank you for your attention.